first presentation.
Thank you, Tom, and thank you all for joining us. We are very excited to present this webinar and for the conversation with our amazing guests. Just a quick intro for Action Canada for Sexual Health and Rights. We are a national organization working to advance sexual and reproductive rights through law and policy change. We also have a health promotion program to provide sexual health information to the public and connect people to services and resources. At the international level, we work with partners across the global south and north to advance sexual and reproductive health and rights globally, combining our efforts in spaces like the UN Human Rights Council in Geneva. Next week is Sexual and Reproductive Health Awareness Week, or SRH Week, and we are very excited to celebrate it with you all. SRH Week is an important part of our health promotion work, as we can use it to promote resources for diverse audiences on different topics related to sexual health. It is also an amazing opportunity to get important conversations going. Awareness days can play a role in galvanizing people's attention and energy towards topics that matter, so we can rally around shared needs, goals, and strategies in building enabling environments where people can be healthy and thrive. A little bit of history. So at this point, SRH Week has been going on for over 19 years. In 2003, SRH Week, which was then SRH Day, was created in partnership between the Public Health Agency of Canada and the Canadian Federation for Sexual Health, which was a predecessor of Action Canada, as a toolkit for service providers to help promote sexual and reproductive health to their community, especially to young people. Now the campaign entails a week of social media engagement, as well as the dissemination of content and resources promoting the work of many of our partners and highlighting important voices around generally under-discussed topics in sexual health. That brings us to this year's campaign, which will be taking place from February 14th to 18th with the theme SRH Week 2022, Advocacy in Action. Our goal with this year's theme is to build on the annual opportunity SRH Weeks offers to get everyone talking about the importance of advocacy as a strategy and practice within public health. We wanted to talk about the different ways advocacy can contribute to addressing the social determinants of health and improving health equity. I'm sure it's going to be news to no one in this room that health inequities are health differences between population groups that are systematic, avoidable, and unfair. And so health equity means working towards all people reaching their full health potential and not having them being disadvantaged because of socially determined circumstances like race, gender, sexual orientation, ability, etc. This is of particular importance for sexual and reproductive health outcomes because despite its importance to our overall health, sexual and reproductive health is not only shaped by social determinants of health, but also deeply impacted by stigma and taboos surrounding matters like sex, pleasure, abortion, or adolescent sexuality. As a result, sexual and reproductive health and rights issues are often ignored, neglected, or actively written out of medical schools' curricula, health institutions, or government policies. This is typically justified by the labeling of parts of sexual and reproductive health care as controversial or inconsequential, and it disproportionately affects the most vulnerable marginalized populations in Canada and globally. In the area of sexual and reproductive health and rights, to win more access to services and to see our rights respected, advocacy is often a necessary activity. Advocacy should not be a scary word. It means trying to make changes and has been an important part of many public health achievements over the past 100 years. There are many ways public health practitioners can engage in, support, or contribute to advocacy. First, they can be part of important conversations. Framing issues is important for analyzing a problem and coming up with effective strategies for change. Healthcare providers, from their experiences with patients, can help identify what changes will advance public health interests and what it will take to make the changes happen. The goal is to influence those who have the power to change laws, policies, or programs, enact policies, or fund interventions that can influence whole populations. Our guests today will give powerful examples of important conversations healthcare providers can participate in. Healthcare providers can also support the gathering of data and to support research. Public health has a critical role to play in generating data and providing information to partners for advocacy. Healthcare providers can also be key partners in coalitions and alliances, leveraging the social capital of their profession. The most powerful public health advocacy occurs in contexts where many groups and individuals are involved, representing diverse and distinct roles. Healthcare providers also can be advocates for their patients and those they serve, taking actions that are aimed at supporting and empowering individuals in disadvantaged circumstances and using person-based strategies. All of this work is most effective when integrated into a broader strategy that combines both bottom-up and top-down advocacy. This means supporting our patients to ensure they have access to services and care, and then locating the cause of health inequalities in the overarching sense to promote change at the structural level. Our efforts should be all along the upstream-downstream continuum to have a significant impact on improving health equity. In Canada and all over the world, advocates fought and are still fighting for access to contraceptives, abortion decriminalization, effective treatments for HIV, gender-affirming surgeries, comprehensive sex ed, to stop harmful practices, and much more. So much progress has been made due to the tireless work of people who wanted better for themselves and their communities, and so much is still left to do so that no one is left behind. A short walk through some examples of advocacy for sexual and reproductive health in Canada will hopefully help to bring this conversation to the realm of what we are familiar with. There are many examples to pick from to get a sense of the importance and the need for people and organizations to speak up and actively work for change to achieve better sexual and reproductive health outcomes for themselves, their communities, and those they serve. Though many of you will be familiar with them, to revisit some of them is helpful to see the importance of this conversation as we take in the trajectory of people's access to services and information key to having autonomy over our sexual and reproductive health and lives, and then what work is left to do. The history of the decriminalization of abortion is one of those stories. For the whole of the 19th century and most of the 20th, abortion was illegal in Canada. The punishment for procuring an abortion was life in prison. Beginning in the 60s, pressure to decriminalize the practice began to rise from medical and legal professionals, women, and social justice groups, and most notably, the Humanist Fellowship of Montreal, run by Dr. Henry Morgentaler. In response to public demand, the federal government introduced the Omnibus Criminal Reform Bill. That Omnibus bill is often hailed as having decriminalized abortion and homosexuality, but this legacy is very rightly disputed. Clause 18 of the Omnibus bill allowed for limited access to abortion, but only under certain conditions. Abortions could only take place at hospitals with the consent of a therapeutic abortion committee of at least 3 doctors. In most hospitals in Canada, this just did not happen. All other abortions remained criminalized. The feminist movement responded to these limitations the next year with an event known as the Abortion Caravan, which included a demonstration that shut down the House of Commons in Ottawa. I just realized how interesting it is that we are in the midst of another type of caravan currently in Ottawa. Activists had to wage a long social and legal battle to expand abortion access after 1969. All the while, doctors like Dr. Morgentaler and Dr. Scott were providing illegal abortions in their clinics. All those people were the force behind the movement that led to the decriminalization of abortion in 1988, when the Supreme Court of Canada struck down the abortion law because they said it prevented women from having equal access to abortion across the country. Of course, there is much more to this story, and it doesn't stop in 1988, but even a brief recount shows the decades of dedicated work that it took to get an expansion of reproductive health care services. To this day, we continue to work to increase access to abortion in rural and remote communities, for undocumented people, for incarcerated people, and for young people, among many others. The work is ongoing to make sure that it's not only some of us who have access to it. The decriminalization of contraceptives follow a similar arc. In the early 20th century, fertility inhibitors could be purchased in secret by couples in the know, or more likely the couples with a higher income. Couples of a lower socioeconomic standing were less likely to be able to access the existing birth control options. In the 20s, the first advocacy group is formed in Vancouver, calling for not only making birth control legal, but also accessible and free for all who wanted it. At the same time, an underground network of doctors who provided birth control options was established. In the 30s, A.R. Kaufman, a philanthropist who also believed in eugenics, created a birth control program for low-income women in Kitchener, Ontario. He paid for one of his employees' legal fees after she got arrested for passing pamphlets on contraceptives, which paved the way for such health promotion work. In 1932, Dr. Elizabeth Bagshaw opens the first official birth control clinic in Hamilton, even though it was illegal to do so. In 1969, with the Omnibus bill, contraception is legalized in Canada. Jump to now, and there is still much to do to ensure people's contraceptive of choice is accessible and they can pay for it. None of these milestones fell on people's lap. Every step of the way, there were people pushing for change. Today, there continues to be a lack of public funding for contraception, which impacts some people more than others. Gaps in drug coverage disproportionately affect certain people, and so this is an equity issue that many people are working hard to change. Currently, over half of pregnancies in Canada every year are unplanned. The Society of Obstetricians and Gynecologists of Canada recently published studies showing that the most used birth control methods in Canada are the pill, the condom, and the pull-out methods. Those are not the most effective, but they are the cheapest. And then, while some people may have trouble getting access to the contraceptive methods they'd prefer, others are robbed of choice to begin with. This is a segue to another important aspect of advocacy, which is advocacy against harmful practices. While it may seem obvious to speak of winning access to abortion care and contraceptives, when we talk of the important milestones of reproductive health care, the fight against eugenic policies has also been pivotal. Eugenics is a set of beliefs and practices centered around the conviction that the human population can be bettered through controlled reproduction. Many Canadians supported eugenic policies in the early 20th century, including some prominent medical professionals, politicians, and feminists. Both Alberta in 1928 and British Columbia in 1933 passed sexual sterilization acts, which were not repealed until the 70s. Over 2,400 people were sterilized forcibly between those two provinces between the 20s and the 70s. Although often considered a pseudoscience of another time, eugenic methods have continued to this day, including through the coerced sterilization of Indigenous women and the disproportionate and non-consensual use of long-acting reversible contraceptives like Depo-Provera on young racialized people. The forced sterilization of Indigenous women and people is not a thing of the past. In 2017, 60 Indigenous people in Saskatchewan sued the provincial government, reporting that they had been forced to accept sterilization before seeing their newborn babies. Them speaking out led to a review by the Senate's Human Rights Committee after much media attention sparked a national conversation on the topic. Their report on the matter highlights how racism and paternalism led to the view that sterilization is for some people's own good. These attitudes and beliefs continue to underpin health policy today and contribute to the practice of coerced and forced sterilization, contraceptive use, and birth alerts, especially for Indigenous people, Black people, people of color, disabled people, and of trans people who in some provinces are forced to undergo sterilization to change their gender markers. In an important report called Girls Without Barriers, the group Dawn Canada compiled and shared the experiences of young disabled girls and gender diverse people regarding their sexual and reproductive health and rights. Those who shared their stories spoke of the lack of appropriate health services, sex ed, and information for disabled people, the rates of sexual violence they experience, and, among many other things, the steady increase in the rate of incarceration of girls and young women with disabilities, with racialized girls and young women especially affected by this issue. Criminalization and incarceration are dangerous stressors, and the trauma from those forms of violence is intergenerational and community-wide. The World Health Organization has recognized that the specific sexual and reproductive health and rights needs of women are not met by prisons, and that the imprisonment should be a last resort. Both certainly have a deep impact on people's ability to access sexual and reproductive health care, as we will hear more from one of our guests who works to counter that. In the last years, we have seen a rise in consciousness and of protests around the impacts of racism and the over-policing of Black, Indigenous, and racialized people. Sexual and reproductive health and rights are severely impacted by systemic racism and criminalization. Racism, including anti-Black and anti-Indigenous racism, impact health outcomes and shape people's experiences in healthcare settings. This is well documented. In Canada, 2 recent studies look at the specific experiences of Indigenous peoples in healthcare, one being Dr. Janet Smiley's First Peoples Second-Class Treatment Report, and the recent report from the review by the Honorable Dr. Turpel-Lafont called In Plain Sight, Addressing Indigenous-Specific Racism and Discrimination in BC Healthcare. I invite everyone here to take the time to read them. We will also get to hear more from our guest speaker about her work in pushing for change and addressing these harms. So what about becoming an advocate? How does that implicate us in healthcare settings, social services, and public health units? As healthcare providers and public health actors, we can look around us and see where the status quo doesn't serve people and how we can help build healthier environments that truly support people to thrive. It is increasingly recognized that to improve population health, health equity needs to become a priority in the health sector, and the measures to reduce disparities must be part of our practice. As I said earlier, advocacy should not be a scary word. It's meaningful and important work that connects us to our community, to our own well-being, and that of those around us. It has been crucial to achieve some of what we consider normal and par for the course today, and is key to work towards achieving better sexual and reproductive health outcomes for all. This year, Sexual and Reproductive Health Awareness Week puts the spotlight on change makers who have led us, inspired us, and worked hard to transform people's lives. It is now my pleasure to pass the mic to 2 incredible healthcare providers and advocates who can share with us how they have come to work in sexual and reproductive health, how they have become advocates, and why it matters. First, we will hear from Claire Dion Fletcher.
Thank you, Fred, and thank you, Tom, for the introduction, and to Fred for that discussion about advocacy. So I've already been introduced, so I'm not going to introduce myself again, but I do want to talk a little bit about my sites of privilege. So when talking about advocacy or equity or social justice, which I think are kind of all tied together for me, I think it's important to acknowledge our sites of privilege and to understand and to question why some people's voices are heard and others people's aren't. And when we do advocacy work, it's important for those who we work with to have an understanding of where we are coming from and what experience we are speaking from. So I'm not here today speaking for all Indigenous people or all Indigenous women or all Indigenous midwives or even all Lenape Potawatomi women. I'm speaking from my own experience as a cisgendered, often white passing Lenape Potawatomi and mixed settler woman and midwife. So another site of privilege is that I'm very grounded in who I am as an Indigenous woman, mostly due to my familial relationships. So I grew up in a suburb. I didn't grow up on reserve. We are disconnected from my family on reserve, but I have extremely grounded and deep understanding of what it means to be Indigenous because of my mom, my grandma, my aunt, my uncle, my siblings, and how we were taught and how we grew up. And this continues in my relationships that I have developed over the years with colleagues. It continues as I see my niece and nephew grow up and live their lives. It continues with the clients who I make relationships with and the babies I deliver and the work that I do. Another site of privilege is my comfort level in academia. So I really feel like at times I've really grown up in academia. My mom was an elementary school teacher for a lot of my childhood. And when I started, I think grade 1, she started her master's and PhD in education. And so I spent a lot of my time learning from her and seeing what she was doing. And she taught me what pushing against mainstream academia can do for our communities. And my experience means I've been able to do well in school and had the privilege of being formally educated in a colonial system that is respected by others. So there are benefits and downsides to this, but my comfort level in this type of colonial institution is important for understanding how I'm able to push against them and advocate for change within the systems to better meet Indigenous people's needs. And it's extremely important to acknowledge that this is not everybody's experience with school and with the healthcare system. It isn't even everybody in my family's experience. And we really need all different types of advocacy right now in the healthcare system. So when I was asked to do this webinar, I was quite excited about the topic that was chosen to focus on this year, as I believe as an Indigenous midwife and a teacher and a researcher, that advocacy is really one of the most important parts of my job. And I wanted to start by talking a little bit about what I think advocacy is and a tiny bit about what I think it's not. So I really learned about advocacy from my family. And so I wanted to start with a quote from my grandmother, which is, "We survived because we took care of each other." This is what my mother learned from her mother, my grandma, and it's what she taught me and my siblings. Despite growing up in difficult living conditions on her reserve and facing discrimination and gendered racism from society and from government, my grandma was committed to providing a good home and a good education for her children. Grandma was always taking care of the people in her life and her family, supporting her siblings through the turbulent times that systemic racism and colonialism can cause in Indigenous families. This lesson of caring and survival continued on in my generation with my siblings. And my mother taught us through the way she raised us, the way she loved us, the way she cared for us, for her family, the way she loved us, the way she cared for her family and through her work. Sorry, I got distracted by the chat. I actually don't have a presentation. I don't love PowerPoint, so you just get to hear my voice. So when I was in elementary school, I both looked forward to and dreaded getting to our lessons on Indigenous people. It was always the last topic of the year, which often meant we didn't actually get to it. I looked forward to it because I hoped to see a bit of myself and my family and our ways of knowing and reflected in what we were taught. I also dreaded it because it never ended up being what I longed for. Inevitably, teachers would be unprepared to teach these topics, and the results of that ranged from inaccurate information to racist encounters in the classroom. And almost always, though I don't know why I said almost, because it was really always, a phone call between my mom and my teacher. Now, as an elementary school student, I often felt embarrassed by these interactions. But really, ultimately, I learned the importance of accurate representation in education and to be proud of Indigenous ways of knowing and being. These interactions often resulted in a different understanding of Indigenous people for both my teachers and fellow students as well. So I spent a large portion of my school years figuring out how to incorporate Indigenous content into my schooling, whether it be requesting different books for reading assignments, focusing assignment topics differently. I did this all with my mother's guidance, encouragement, and sometimes a bit of pressure. I didn't always want to do this, and I really didn't like challenging the status quo, which I think is a line that is going to have some of my colleagues who I know are here laughing a bit. And I didn't always like doing things differently. However, I knew this was an important part of how my mom instilled in me lessons about indigeneity, feminism, and the importance of using education as a tool to learn on your own terms, which eventually turned into an understanding and a belief that we can change our current systems to be beneficial to Indigenous people to meet the needs of our communities. So very briefly, I want to talk about what I think advocacy is not. So for me, advocacy is not paternalistic. My advocacy work is not about giving people agency, empowering people, or giving people a voice. Now, when I say this, people often get a bit confused, but bear with me for one moment. So for me, these are not things that someone gives to other people. Agency, empowerment, and a voice are things that people empower actively block from others. And to me, advocacy is about working in relationship with each other to identify these barriers and then using our collective skills to break them down in order to improve our collective health and well-being. So I want to talk for a minute about different levels of advocacy. And I'm going to use a teaching around a notion that many Indigenous people refer to as the three sisters to help explain my understanding of the role of different levels of advocacy. So this understanding that I have is heavily influenced by my time working alongside my colleague, Métis midwife Natalie Pembrin, who I've learned a lot and done a lot of advocacy work with. And just to say, for sake of time, this is a very simplified analogy, and you will hear different ideas about the importance of the three sisters depending on which Indigenous nation you're speaking from. So the three sisters are squash, beans, and corn. And these are crops that are planted in a symbiotic way to work together. Stalks of corn offer beans support as they reach for the sunlight. Beans provide beneficial nitrogen to the soil to help fertilize the corn and the squash's broad and spiny leaves protect the beans and corn. So I like to use this to talk about the different kinds of midwifery and midwifery advocacy. So we have our midwives on the ground who, like the squash, are close to the grassroots. They're rooted in the needs of community. They're at the grassroots level. And often they're meeting the individual needs of community members outside of the systems that we're used to working in. So they're really caring for our community members who are outside of the system and have trouble accessing the healthcare system. And this is incredibly important work that is rooted in community. So then we have the beans, which are midwives who are working in the systems, in hospitals, in the healthcare system, but also their work is trying to push against and change that system and really trying to rethink our healthcare system. And then we have our corn, who are, our midwifery leaders and policymakers. The corn grows tall and is able to really see the big picture and to think about all the squash and the beans and what our needs are and how we work together and how policy can be changed to ensure our needs are met. But they need the support of the beans and the protection of the squash. So each of us contribute, and each of these different levels contribute to an important part of the whole narrative. Each have a piece of the solution that is going to carry us forward. And all three levels of midwifery or midwifery advocacy are crucial to meeting the needs of Indigenous people. So this is a little bit about kind of what I think about advocacy. And for me, advocacy is about relationships, about bringing our skills to the table, about our responsibility to each other, and understanding that we all play different roles, but all of these roles are necessary. So I wanted to talk a little bit specifically about advocacy in the healthcare setting. And this, to me, really, to understand the importance of Indigenous midwifery and our role in advocacy, we need to really understand the landscape that we're in. So as an Indigenous healthcare provider, I'm providing care in a system that wasn't designed for me or the clients who I provide care to. And not only is the healthcare system not made for the health and well-being of Indigenous people, but the healthcare system has been actively used as an intentional tool of colonization and is therefore fundamentally not about the health and well-being of Indigenous people. I'm going to just briefly name a few things that our healthcare system is based on. And I'm just like giving a quick list, and I'm hoping that everybody who is here can just agree to this, or if you need more information, there are many resources out there that people can turn to talk about these things. But the healthcare system and our understanding of health and resources that we use to keep people healthy in this country have been built on and based on the experimentation on Indigenous people, including children in residential school, experiments that led to starvation and the death of Indigenous people, and extreme racism in the healthcare system. So for many people, the healthcare system is where you go to get better. If you're sick, you call your doctor. If you're urgently sick, you go to the hospital. However, this is not the case for all people, and particularly for Indigenous people. So I see one of the most important roles as a healthcare provider is to advocate for system level change. Our entire system needs to change to provide healthcare access to Indigenous people, which is our right. So what are some of the things that I advocate for? So I advocate for the growth of Indigenous midwifery and the return of birth and midwifery to all of our communities. For me, the return of birthing practices and Indigenous midwifery is really about the sovereignty of our bodies, our healthcare, our political systems, our language, and our land. Violence against Indigenous women, girls, and Two-Spirit people and our knowledge was a direct and active tool of colonization. We have many examples of different types of violence and control. So we have, what we sometimes think of kind of as like more direct violence, such as the murdered and missing Indigenous women, girls, and Two-Spirit people, which we have multiple reports that have highlighted this as an issue that needs to be dealt with. We have control of Indigenous people's reproduction through forced and coerced sterilization, as Fred talked a little bit about in the opening. We have a control through an attack on Indigenous midwifery and our knowledge and our skills and our practices around birth through the medicalization of birth. And we have control through control of our families, through the apprehension of our children, through residential schools, the 60s scoop, the Millennium scoop, the current child welfare system, which includes birth alerts in hospitals. So when I'm looking at this list, and I'm just going to kind of highlight it again, which is direct violence, control of reproduction through forced and coerced sterilization, control of our ways of being and our knowledge systems, and control of our families through the apprehension of our children and taking children from our families and putting them with other families. We actually have a word for what these things are. And internationally, these are all things that are known to be a direct part of genocide on a people. And so for me, working as an Indigenous midwives, my job is to every day actively resist these levels of control. So as an Indigenous midwife, I have a key role in building healthy and safe Indigenous communities in rural, urban, and remote areas. Indigenous midwives respond to the unique needs of Indigenous communities. This awareness allows us to better understand the barriers they face and to transform the systems that perpetuate oppression. So when you look at midwifery in Canada, it looks different everywhere you look. So whether it is, the Inuit midwives who work in northern Quebec and Nunavut, who have a midwifery program and an education program that is based in the land, in their language, in their families, whether it's the Haudenosaunee midwives who work at Six Nations at the birth center, who also have an education program and a midwifery program that is based in the land and their language and their community. If you look at the practice where I work at in downtown Toronto, 7th generation midwives, where we bring together a diverse group of Indigenous nations and midwives to try to best provide care to our diverse urban community, where some of us are working in the hospital and some of us are working at the grassroots community level, really trying to meet our community needs. If you look at midwives working at birth centers in Winnipeg or midwives working in downtown Vancouver, all of our care looks a little bit different. There's things that unite us, but there's also things that are different. And this is because our role as Indigenous midwives is to respond to the unique needs of our own communities. And this allows us to ground our care in our communities and to be able to meet their needs and to really have at the center of our care the pregnant people in our communities, the babies, the elders, the adolescents, everybody who needs to benefit from midwifery care. And this is how we help to transform the systems that perpetuate oppression and ensure that our programs meet the needs of clients. So as midwives, we promote the self-determination of our people, our families, and our nations through the way we provide care. The very way that we provide care to our communities is advocacy. We prioritize respect and relationality. We center clients' voices and promote autonomy. We meet people where they're at in their journeys. We take a harm reduction approach and a trauma responsive approach to our care. Informing people of their health and their rights and options promotes informed choice and control over decision-making and knowledge about our bodies and our rights and how those work in conjunction with other people in our lives and our relationships with other people and the land and our communities and ultimately our nations. And we bring Indigenous knowledge and practices to the care that we provide in our advocacy roles. So advocating for Indigenous midwifery is, in my opinion, crucial. All of our communities have a right to high quality, clinically excellent, culturally safe midwifery care. And ultimately, Indigenous midwifery is culturally safe care. So I wanted to just briefly talk about kind of some of the ways that we can advocate for Indigenous midwifery and the return of birth. So NACM is the National Aboriginal Council of Midwives. We do a lot of policy work. So we do things like writing position statements. We chair different councils and committees, working alongside partners at all levels of government, health authorities, programs, healthcare providers, all working together to meet the needs of our communities. We work alongside individual communities to grow Indigenous midwifery and Indigenous midwifery education opportunities. And we're also participating in new research. Our members are doing clinical work, meeting the needs of individual clients, creating innovative models of service delivery that are community-centered and community-based, and work within hospitals to change the healthcare system. We also have a role in teaching and improving access to midwifery education and really diversifying the pathways to education. So I really think that one of the things that we really need to do is to change the way that we are providing sexual and reproductive health care. We are in a system that is actively contributing to poor health outcomes for Indigenous people. We are using incomplete data and inadequate research that isn't Indigenous-led and doesn't show the diversity in our experiences, and data that isn't disaggregated. And this is what we're using to build our solutions and our programs, and this is not going to work. We need to take a reproductive justice approach to sexual and reproductive health, one that focuses on our relationships with each other and the synergy between these relationships, one that takes into consideration the landscape we are working in, and that centers the needs of our people and our communities. This is how I think we will get the diversity in healthcare that we need for our communities to flourish. This is how we will survive, by taking care of each other. Anashik, thank you.
Thank you so much, Claire. Your students are very lucky. I could listen to you talk all day, as are the babies you welcome into the world and the families you support. I would now like to pass the mic to Martha Painter.
Hello, thank you. And thank you for that presentation, Claire. You can go to the next slide. I've already been introduced. Thanks, Fred. So I wanted to shape this around how I have been integrating advocacy within my sexual and reproductive health nursing practice. As Fred mentioned, I work clinically in abortion care, and I also work in postpartum care. So I will be speaking to different aspects of that. Next slide. Before I begin, I acknowledge that I am located in Halifax in the unceded, unsurrendered land of the Mi'kmaq people. And here we have a situation where 4%-ish of the population identify as Indigenous, and yet a quarter of the children who are in foster care are Indigenous, and at least 7% of provincial prisoners are Indigenous. Within that group, in the provincial prison designated for women, the number rises to 15. So we see all those very black and white stats that coincide with what Claire described, these genocidal processes. Next slide. So when we do a land acknowledgement, when I do a land acknowledgement, I always want to make clear that there has to be a substantive, a meaningful commitment to action that accompanies that acknowledgement. You cannot acknowledge genocide and then just keep merrily along. In the Truth and Reconciliation Commission report from 2015, there were dozens and dozens of calls to action, and these are some of the calls to action that my work and my work in partnership addresses. Number one, reducing the number of children, Indigenous children, who are in state care, to recognize the health rights of Indigenous people, which Claire explained in depth, how those rights are not met. Increase the numbers of Indigenous healthcare providers and eliminate the over-incarceration of Indigenous people. One would hope to eliminate the incarceration of Indigenous people. Next slide. Claire also introduced the concept of reproductive justice, and I think it's become quite well established within the field of sexual and reproductive health that we are best served when we join this movement and acknowledge the leadership of Black feminist leaders in the US who first coined this term, and the other people of color, Indigenous women, who lead this movement. And this speaks to moving beyond abortion as the focus of our reproductive rights activism, a very white feminist focus, to expand concern to the right, not just to not have children, but to have children, and to have those children live in safety, and safety from state violence and state interference. Next slide. In nursing and in most health professions, there is a code of ethics that governs practice. And for nurses, this code very clearly states that it is our job to promote justice. And I interpret that as going beyond individual advocacy efforts with individual patients to a political responsibility to engage with social injustice at that macro level. Next slide. And as Claire also introduced, there is in our profession, often touted as the most trusted profession in the world, there is a very dark shadow side to nursing. Nursing has been characterized, built on social tenets of sexism, racism, colonialism, ableism. There is a inherent understanding of nursing as handmaidens to medicine in a very heteropatriarchal hierarchy within clinical care. Just an example of this is all of the rhetoric, the horror when female physicians are misidentified as nurses in their practice. So there's the sexism that we operate within, right? The exclusion of non-white women from the profession. And in Canada specifically, we have a long history, only recently begun to change, that specifically excluded Black women, Indigenous women from studying nursing. The earliest Canadian nurses, Black Canadian nurses, Indigenous Canadian nurses, left Canada to be trained and came back and served their communities. So in addition to this systemic history of exclusion, there's the actual violence of our current practice. Some of the most obvious examples are how we as nurses, our unions, our professional organizations leap to violence as the impulse. Just an example that came to mind in relation to the COVID epidemic and responses to the COVID epidemic, how there have been calls for policing of hospitals, and how that happens also within hospital spaces, right? For patients to walk into a hospital and the first thing they encounter is the security guards. It creates a whole space, a whole environment that is threatening. And as nurses, we normalize that as part and parcel of our acute care practice. And there needs to be a reckoning with why we are so comfortable with that as a profession largely made up of white women like myself. Why is there that comfort with being so closely married to security forces? There's also the issue of nursing's engagement directly in abuse of patients. And some of the examples that have generated the most media attention in recent years would be the death of Brian Sinclair, who was killed because he was neglected while waiting in an emergency room in Winnipeg, and Joyce Ekequan, who was verbally attacked during her death by white nurses. And those nurses later, when called upon in an inquiry to reckon with themselves, said, I don't even recognize myself in these videos of my behavior. And so that's what I'm talking about, this reflection and recognition that this profession has a dark side and it's very easy to fall into its darkest trappings. Next slide. So while we are, having said all that, and recognizing this idea that we are the most trusted profession year after year, we remain invisible, right? Despite all of the attention on the healthcare system, minute by minute during the past 2 years, there has been a really, you can't even explain how excluded nurses are from the conversation about what's happening in hospitals and on the ground in terms of public health. Nurses are not asked. Nurses are excluded from engagement in public conversation about health services, health care. And yet, nursing is by far the largest workforce in the health system. There are 400,000 nurses in Canada, and so more than 1 in every 100 people in this country is a nurse. So there could be this huge impact if there were that collective willingness to engage politically. But there are these systemic factors that prevent that from happening. And of course, part of that is the heteropatriarchy. There's an exclusion of nurses from health leadership positions. There's also an internal policing within the profession of our actions and words, a very racist and colonial notion of what constitutes professionalism in this profession. So don't talk back and don't be too aggressive. So in the past couple of years, there was the year 2020, year of the nurse, as well as the pandemic, that opened up platforms for nurse voices and nurse advocacy. And yet the advocacy in question often became about themselves, ourselves. Do we have enough PPE? Do we get paid enough? Are we adequately staffed? And these are very important questions. But if nursing is to meaningfully engage with advocacy, there has to be a consideration of justice issues beyond our own professional roles. Next slide. So nursing and advocacy. This is an extraordinary history of individual nurses who have made an enormous impact. I think people perhaps don't know that the great abolitionist Harriet Tubman was a nurse. One of the examples that I like to draw on in recent months is Dawn Wooten. There's a picture of her right there, who was an LPN and working in Georgia. And she came out publicly. She was a whistleblower about the mistreatment of people who were being held in immigration detention in that state. She spoke out about forced sterilizations, which, as Claire and Fred both spoke about, is one of the most obvious forms of reproductive coercion that is disproportionately pushed on Black and Indigenous women communities. So her whistleblowing, this extraordinary work that she did towards justice for these people, came at an enormous personal cost. She was demoted, and then she was blamed for being complicit. And so this is one of those areas where nurses face some friction. How do I call out what I am in the mess of, what I am in the middle of? Another problem with nursing advocacy is how the profession self-regulates, and how that self-regulation can be policing. So a very well-known example in Canada in the nursing community is what happened to Carolyn Strong, a white woman who was off duty and commenting on her own private Facebook account about the poor nursing care in general, that her grandfather was receiving in long-term care. For her unprofessional behavior, she was disciplined by the Saskatchewan College of Nurses and fought a 5-year legal battle, which she eventually won. She was going to have to pay $27,000 in legal fees. So here you have an example of who decides what constitutes professionalism. Shouldn't it be professional to call out injustice, to call out mistreatment, if your code of ethics requires you to promote justice? And yet, embedded in the profession is this heteropatriarchy, racism, colonialism that silences and that requires nurses operate in these very tightly defined roles, the white cap and the white uniform role. Next slide. Some of the advocacy work that I do, very much as Claire was talking about, and a beautiful definition of advocacy, you don't empower anyone else, but you can create conditions so that people have power in themselves and can actualize that power. So one of the issues with abortion access in Canada, Fred described the process of decriminalization, but the problem is people don't learn about that. We hold that information hostage. So everybody has the right to have abortion on demand. There's no limitations, gestational age, it's free, and people don't know that. Instead, they're bombarded by US news that, unsurprisingly, clouds understanding of how things work. And so one of the things we can do is talk about abortion all the time and make sure that we're graduating healthcare professionals that know exactly how they can support patients to get an abortion, that they are telling patients true information. So as Claire was saying, the patient can make an informed decision. Right. So one of the things we're doing here at Dalhousie University, where I teach, is we created an interprofessional abortion course. There's midwives on the team, nurses, nurse practitioners, social workers, and of course physicians. And we work together to teach students in all those different faculties about their different roles in this care, so that they feel confident and competent to do the care. Next slide. Another example that I work a great deal in is in relation to prison abolition. So this is a whole huge topic in and of itself, but the research is very clear that prisons are unsafe, they're dangerous, they're deadly. And they're inherently incompatible with the principles of reproductive justice that we've already talked about, right? That you can govern your body, that you govern what happens to your sexual health, to your reproductive health, to your family, that your children aren't taken from you and you aren't taken from your family, etc. So prisons are incompatible with healthcare. Nurses, being the greatest size workforce in healthcare, have an obligation to consider how our work intersects with the carceral system. So I do a lot of teaching about how criminalization is a social process. It's laws are things we make up. We decide what gets to be criminalized. For instance, substance use, sex work, things that are not criminalized in other places, and we don't have to criminalize, but we do. We choose to. So criminalization is a process that happens, and it could be changed. And it's based on inequities that Fred already talked about. You are more likely to be criminalized if you are Black and Indigenous, if you are trans and non-binary, if you are experiencing chronic illness already, if you have an injury. A quarter of the people in prison have a traumatic brain injury, just that one stat alone. So nurses have an obligation to understand how that works, and then to be available to efforts to decrease reliance on the carceral system. One of the things nurses can do is talk about things that matter in people's lives that should be considered in relation to sentencing, right? Just the most obvious one in my work is it really matters to an infant's health if their primary parent is taken from them. That makes them less well, makes that primary parent less well, a birthing parent less well. There are clinical reasons to keep parents and babies together and not to put them in prison. And then nurses have a role to play in advocating for those big social issues that prevent reliance on prisons. Right? We spend $2.4 billion on federal incarceration in this country every year, and we could be using that money for all kinds of things: livable income, housing, and as Fred was talking about earlier, pharmacare. So people can be in charge of their own bodies, can have that autonomy, can govern themselves, You don't need to be empowered to plan your family. You need to have free contraception, right? So what are those mechanisms that we can be part of making those realities for people in Canada? Next slide. This is a beautiful and short quotation from Dr. Cindy Blackstock, who is a national leader in work to advance the rights of children, Indigenous children in this country. It's not enough to know about it. It's not enough to care about it. You have to do something about it. And nurses are doers, right? This is a very task-oriented profession. So we can do the work of advocating for social change. I think that's it. Next slide. Yes, there's my contact. Thank you so much, Fred.
Thank you so much, Martha and Claire. It's such a pleasure to be in conversation with the both of us. And I think you gave us a lot of food for thought and great, powerful examples of the kind of conversations we need to be having as people who are public health actors, healthcare providers, and involved in any kind of health policy. For the attendees, there will be time for questions shortly. Before that, I just want to give a short overview of what you can expect during the campaign, and also say that the recording of this presentation will be available, unfortunately only in English, on Action Canada's website in the next few days. If you desire to share it, if you desire to rewatch it, or if you want to share with your community. As usual, we hope that as many individuals and organizations will participate in SRH Week to make use of the opportunity to put sexual health in the spotlight and spur conversation in their office or community or with their colleagues, in their clinics and their hospitals. And so if your organization is hosting any kind of event or want to promote a spotlight on a change maker among your colleagues or your organization during that week, if you want to promote a specific activity like a webinar or a fundraiser, please let us know so we can put it on our SRH Week calendar and promote it. The contacts for Action Canada will be made available, of course, at the end of this presentation. Every year, we also offer a poster that you can hang up in your waiting room, office, clinic, hospital hallway, or community center to highlight Sexual Health Awareness Week. If you want to order some, please visit our website. During the week, we will also unveil 5 beautiful and collectible postcards produced by individual artists who have illustrated the stories of 5 organizations and individuals we have chosen to spotlight during the week. The featured stories go from local to global, ranging from someone leading a student walkout in their school to a community organizing to decriminalize abortion in Ecuador. We opted to do that to really show that in our struggle for advancing sexual and reproductive health and rights, we are connected to a global community of change makers and people who care about human rights, and that we have a lot to learn from one another. Finally, we will be on Facebook, Instagram, and Twitter too. Find us at Action Canada SHR or download our social media kit at www.actioncanadashr.org at Campaigns SRH Week. It will be available in very shortly to participate on those platforms. The new campaign and material will be available on our website as of February 12th. And for our team, getting the conversation started on the importance of advocating for change is so excited. And we are so excited to have so many of our colleagues on the line. So thank you so much for joining us today.